Today I have the privilege of introducing our expert, who is going to be talking about the latest innovation from MST. MST is a company that was founded on solving distinct clinical problems with really innovative solutions. And today, our speaker, Dr. Chris Pohl, is the inventor of a device called ArcDUO that we feel strongly fits in that legacy of products. And so it is my pleasure to introduce Dr. Chris Pohl with the Cokington Eye Institute.
Thank you. So yeah, this has been a project that has been a passion of mine for quite some time. When I was developing it, the target for us was MST. MST has always had a long-standing reputation for solving problems with fantastic products that are just high quality. All right, so what we're talking about is low levels of astigmatism. We're defining this typically in the range of a half a diopter to a diopter and a half, okay? Now this also would include 0 to 0.5 diopters. I think with the current times, I've learned that we've typically said a half a diopter of astigmatism is considered visually insignificant. And I think that's probably because we just didn't have a good way to address a half a diopter of astigmatism. If you look at patients, about 55% of patients will have in that range of 0.5 to a diopter and a half. If you include that 0 to half a diopter, it's up to 75% of patients over different age groups. The effect of this is suboptimal outcomes in our monofocals and expanded depth of focus lenses. The multifocals, these do not work well with residual refractive error. We know this, okay? Torics needing a little fine tuning. How many times that we put in our toric lens, our calculations are perfect, and we end up with a little residual astigmatism. We corrected too much, we corrected too little. When the argument that we're making is we need to treat low levels of astigmatism, and this should be in addition to any, not only premium cataract surgery offering, but across the board to different communities and different practices. So why corneal relaxing incisions? It fits into a family of refractive treatments, okay? Do we do LRIs, AKs in every patient? No, it's not appropriate for every patient. We have these different tools in our toolkits for this very reason. The great thing about this is it can be decoupled from cataract surgery. It's painless, quick, minimizing operating room and laser fears. This is really important. Minimally invasive, we all like things that are minimally invasive. Key is new revenue potential, we'll talk about that, and long-standing effective treatment. LRIs have been around for a long time. We know it's a proven modality to treat astigmatism in low amounts. So first we're going to talk about the perspective through a young physician. Corneal relaxing incisions have changed. The days of the physicians that started doing RK, AKs, and then eventually evolved to LRIs, that's just not being done as much anymore. Those doctors that are comfortable doing LRIs, say LRIs at slit lamp, is declining. But there are barriers to entry to the young physician. Biggest one, over 50% of physicians in the US never did a single LRI in their training. That's critically important. I suspect that number is even higher now. We want to standardize and have a consistent corneal relaxing creation. Finally, every time you're doing these, especially as you're developing your technique as a young physician, what happens is we send them back to our referral doctors. When these other doctors send patients over to you, you create corneal relaxing incisions, and then you look at them under the microscope. That is your signature. Next, we're going to talk about the perspective through an experienced physician. They are obviously much more comfortable with the different methods of astigmatism correction, but there's continued barriers, right? One of the biggest ones is varied patient population. My patients that live in Kansas City, which I think we can all agree is probably the center of the universe at this point, they're much more apt to adopt premium technologies. My patients out in Warrensburg, again, which is about an hour away, they are interested in reducing their need for glasses, but they're not interested in adopting premium technologies, especially if it sounds difficult. So again, I think the point here is an experienced physician knows that they need to have all the tools in their toolkit to address astigmatism and refractive error. Finally, we're going to kind of move to the patient. So what's the setting of the patient now? Increased desire for refractive outcome, highly varied access to resources. We know this patients. Every patient population has a variable distribution of patient resources. Corneal relaxing incisions can be done in the operating room or in the clinic setting. So it's very flexible in that way. It can be done at the time of cataract surgery, or it can be done any time after. It's a low cost, low risk option for patients. Finally, let's look at the practice administrator, okay? Increasing overhead and declining reimbursement. Increasing demand for physicians and physician volumes. We need something that's quick, simple. You add more complexity to my day, and I immediately start to get kind of this trepidation to that. And then convoluted changing insurance environment. CRIs, what they are is low risk, quick, and a non-covered service. This NICIS avoids this issue to a large degree, adaptable to a practice, and it's placed in the market. CRIs can go to any practice. Great source of additional revenue to help us offset the declining reimbursement. So what are the current limitations? When I was in the operating room, I had both access to flax and manual LRIs at this point in my career, okay? But this is the issue. In manual LRI and CRI creation, they're low cost and low tech. The challenges are accuracy, precision, reproducibility issues. So what we really want in this phenomenon is we want all the benefits and we want to eliminate the challenges. And that's where MST has done just a fantastic job with the ArcDUO. This is a device that creates guided, paired, limited depth incisions. You'll see this is the suction base. We call that the blade ring that came off. And then you have these templates. Now, you don't have to use the templates, but you can. What you see is you mark the eye. The beautiful thing about this, the template fits into it. You can orient to any axis you want, suctions onto the eye, secures the eye. The blade ring comes in nests. Your CRIs are created, and then you just release the whole device. The beautiful thing about that is you get flax quality incisions at a fraction of the cost and at a fraction of the time. It also doesn't require expensive laser. So here's a video, and I have to apologize about the video. It moves quick. Suction on. You can see I'm kind of palming or kind of holding the blade ring in my other hand. You nest the blade ring, rotate, perform your treatment, and release. And that's how long it takes. I open them up, they just feel just perfect. Nice and smooth, consistent depth all the way through. So my preliminary experience, very simple, very easy to use. Short learning curve, accurate and precise limited depth incisions, and much more accessible to my patients. What I can now tell patients, which I love, is let's do standard cataract surgery, the standard monofocal lens. We'll let you heal, and we'll see how much astigmatism you have after the fact. So in summary, we had the unmet need, we looked at the current limitations, and now we have a fantastic solution with the ArcDUO. So I appreciate your time, and we'll take any questions that you have.